Hello, and welcome to the COVID-19 and Health Inequities seminar series presented to you by the Center for Communicable Disease Dynamics and the Harvard T.H. Chan School of Public Health. This is the first talk of a 5-part series running through October 22nd. I am your moderator, Emma Accorsi, and today we are excited to welcome Dr. Sweaner from the Johns Hopkins Bloomberg School of Public Health and the Wilmer Eye Institute. Let's get started by covering a few logistics. This seminar is being recorded, so please turn off your camera if you do not wish to be recorded. The recording will be available on our website at a later point in time. Captioning for the talk is provided by White Coat Captioning and is available by clicking the closed caption button at the bottom of the screen or through the link in the chat. At 2:45, we'll stop for questions. Throughout the talk, you can send questions via the chat function to Tiffany Lemon. We are thrilled to have Dr. Sweaner with us today. Dr. Sweaner is an epidemiologist and the director of the newly established Johns Hopkins Disability Health Research Center, which aims to address health disparities among people with all types of disabilities. This center connects researchers and stakeholders focused on maximizing health, equity, and participation of people with disabilities. Her work is fueled by her personal experience with visual impairment, a perspective that guides all aspects of her research. Let's get started. Dr. Sweaner, thank you so much for joining us today.
Thank you. Thank you so much. Thank you to the Harvard School of Public Health, and thank you to the Center for Communicable Disease Dynamics for inviting me. So today I'm going to talk about COVID-19 and disability and the unequal pandemic response that has occurred for the disability population. There we go. I am Bonnie Lynn Sweaner, as I was introduced. I'm an associate professor at Johns Hopkins University and the director of the Disability Health Research Center. So before I talk about COVID-19, I want to first take a few minutes and talk a little bit about disability. And I want to ask everybody to think a little bit about what disability is. When I say disability, what definition comes to mind? What do you think about? What does disability mean to you? And in giving these kinds of talks before, I know that if I used Zoom to poll the audience, I would get just as many different definitions of disability as there are attendees. And that's really an important point that I want you to remember, because there really is no singular definition of disability. It's complex. And we use multiple definitions and sometimes different definitions in different settings. So we'll use one definition in a healthcare setting, perhaps another in research and another in policy. Additionally, people with disabilities often define disability in different ways than people who don't have disabilities. And some examples are that the CDC, the Center for Disease Control and Prevention, define disability as any condition of the body or mind that makes it more difficult for the person to do certain activities, interact with the world around them. However, the ADA, the Americans with Disability Act, which is the law that is intended to prevent disability discrimination in the United States, defines disability as a physical or a mental impairment that substantially limits one or more major life activity. And the WHO, the World Health Organization, defines disability as it arises from the interaction, being asked to restart my computer. Let's hope that doesn't happen. From the interaction of health conditions with environmental and personal factors. But in addition to considering that there's multiple definitions of disability, it's also important to understand that disability is this evolving concept. And over the past many decades, the concept of disability has shifted from what's called a medical model of disability, where disability is defined as the presence of an impairment in functioning or body structure and now shifting towards a social model of disability, where people are viewed as being disabled by society or their environment rather than their bodies. And this has been an important shift in the way that we conceive of disability, because it's largely been driven by the disability social justice movement, which is informed by the perspectives of people with disabilities themselves. But I also want to underscore that not everywhere or in every setting has the social model of disability been adapted. In healthcare and in research settings, the medical model of disability still really is predominantly used, and I want you all to think about that as I go through my talk today. The third aspect of disability that I want to review is that it's common, but it really is heterogeneous. 1 in 4 American adults has a disability, which equates to about 26% of the American population. On this slide, I'm showing a bar graph of the prevalence of different types of disability: mobility, cognitive, independent living, hearing, vision, and self-care. And while that's certainly not an exhaustive list of the different types or categories of disability, this slide is intended to show that disability is an umbrella term, and there's different types or categories of disability that fit within that umbrella. And the differences between those types of categories of disability are important, and we need to honor and appreciate those differences. But there's value and impact to studying disability as a whole, as an umbrella term. The last point I want to make about disability is that it impacts all of us. Not only is it common, but it's the only minority group that anyone can join at any time. And the reason I take time to make this point is because the way we perceive the individuals and the groups that we examine as researchers and care for as healthcare providers, it affects the way that we tackle problems and frame our research questions. And it's important, therefore, to consider that disability is a critical and common component of our community, of our country, of the world. And that, I think, now more than ever, really has become important. So the COVID-19 pandemic has really elevated this connectivity, this thought that public health, national, global health is all interconnected, and we need to really focus on the whole community. But disability really hasn't necessarily been included in that. But when I've talked about disability and COVID-19 before, the first questions I get tend to circle around nursing homes and congregate care settings. And certainly that's important to think about. And there's been a lot of discussion in research and in the media. And on this slide, what I'm showing is a headline from the New York Times highlighting why that is. So this is showing that about 40% of US COVID deaths are occurring in nursing homes. Right? That's really striking, impactful data highlighting the importance of focusing on these settings in our COVID response. And this slide is focusing more deeply on long-term care facilities, which is a subtype of nursing homes. This is a map of the United States showing data from the Kaiser Family Foundation. And it's indicating that of the total COVID cases, those occurring in long-term care facilities are 8%, but of the total COVID mortality across the country, the percent occurring in long-term care facilities is 41%. Again, striking data. There's been recent data looking at COVID-19 in group homes for people with developmental and intellectual disabilities. This is data from New York State, showing that the case fatality percentage is about twice that in those group homes as it is in the general New York State population. And the mortality rate is about 8 times as high. Again, all implying that these are high-risk settings and certainly deserve and need to be a focal point of the response. But the question still really remains why? Why are COVID-19 infection and mortality rates so high in these settings? And there's been a lot of discussion about the fact that there's population density, a lot of people living closely together in these settings, and that there's a number of individuals in these settings who may have underlying health conditions that are at least perceived to put people at greater risk of COVID-19 illness and more severe outcomes. But I'm really interested in digging deeper, looking beyond just that. And there's some recent indication that perhaps that's warranted. There's been discussion in the nursing home data that quality of care should perhaps be considered, although there certainly is lack of consensus there. So there's studies looking at the quality ratings from CMS of nursing home facilities and the relationship with COVID-19 outcomes. And the results really are mixed. Some studies showing there's a relationship and some studies showing there's not. But what all the studies seem to circle around is this idea that health disparities in these settings matter and perhaps are even more elevated in these spaces. So one recent paper, which did not find a relationship between the quality ratings of nursing homes and COVID outcomes, says that facilities with a high percentage of African-American residents are more likely to have COVID-19 cases, which echoes the disparities in the pandemic at large. But another study that recently came from the CDC, which did find a relationship between those quality scores with lower rated ranked nursing homes being more likely to have outbreaks. But that study found that low rated nursing homes are more likely than the higher rated homes to serve patients experiencing social and economic disadvantage who might already be at high risk for severe COVID-19 illness and death. The idea here is this picture might be more complicated, that perhaps we do need to dig a little bit deeper and consider the social determinants and the health disparities ongoing in these settings. But I also think we need to go even beyond that. And the ACLU, the American Civil Liberties Union, started to take that call to action. They put out a news release saying that the COVID-19 disparities in these settings are arising from the decades of indifference, invisibility, and the deadly discrimination against the people who live and work in these settings. Underscoring that the people who live in these settings are different, are thought of differently, and perhaps are treated differently. And maybe that has something to do with what we're seeing in COVID-19. But again, I think we still need to go deeper. Certainly, thinking about those settings, nursing homes and congregate care settings, is an important part of the COVID-19 response. But what about people with disabilities that don't live in those settings? What about them? That's only a fraction of the disability community. The data I showed a few minutes ago about the proportion of Americans with disabilities, that's actually data from BRFSS, the Behavioral Risk Factor Surveillance System, which is data from Americans who don't live in those settings, indicating that a quarter of our community population outside of those settings have disabilities. So how is COVID impacting them? Well, that's a question that I have thought about a lot since early in the pandemic. So early in March or mid-March, I was exposed to 2 people that tested positive for COVID. Not too long after that, I myself started not feeling well, fever, sore throat, chills, and I was referred to get a COVID test through one of the newly popped up COVID drive-through testing sites. And when I got that referral, I thought it was absurd. The reason being is that I myself have a disability. I'm visually impaired. I've been losing my vision for the past 15 years, and I can no longer drive. So the idea that I could get a COVID test at a drive-through test site was ridiculous. But then when I started to think a little bit more about this, I actually really started to get scared, because my options were, as a mom of 2 little kids, living in a house with my husband and my children, to put us all in the car to go get the COVID test I know this was early in the pandemic. We did not have masks at home yet. And I worried as an epidemiologist, as a public health professional, that if I hadn't yet already exposed my kids, if I was in fact positive, I certainly would in the car. If we had someone come care for my kids or take my kids somewhere to be cared for, if I had exposed them, then I would then be exposing someone else. The last option was to take an Uber or rideshare, and then I'd be unwilling exposing someone who would then continue to expose people, whoever got in that car. All seemed very irresponsible, and all felt like this was just an unequal impact that not everyone else was dealing with. Now, I admit I am an extremely privileged individual as an associate professor at Hopkins, but I started to think that if I'm experiencing this, certainly many other people in the disability community are, times manyfold. So I'd started to do the only thing I know how to do, which is research and look for data, and there really wasn't much. And I started to think about why that was. Why wasn't there data on disability? I wrote this article in Stat News, and I'm showing the image of that tagline here on this slide. But those barriers that I started to think about really are critical in understanding the whole picture of how COVID-19 has impacted people with disabilities. So one of the ways that it has impacted the disability community is through the ways that we access information. Getting public health information to the community at large certainly has been a challenge in this time. It's coming out fast and furious and changing. But for people with disabilities, there's also sometimes an extra barrier. We access information differently, and unless that information is made accessible to us, we don't even have a chance. An example of this, I'm showing headlines from the Hill publication, where there's 2 lawsuits brought forth from the deaf community about the lack of sign language interpreters, one at the White House and one to the Cuomo administration. I'm showing both sides of the political aisle to be fair. And the reason this is so important for the disability community is because without this access, how can we respond? How can we do what we are being asked of as the community to protect others if we don't even have the information? At this time in the pandemic, we're all being asked to engage in public health practices, not just for ourselves, but for the health of the community. And that's critical, that's important, that as a public health professional, I endorse that. But then we also have to make sure that information is accessible to everyone. In addition to access to information, access to testing and healthcare has also been a barrier. The barriers I just discussed of getting to testing sites, drive up and drive through testing sites, is not only a challenge for people with vision loss like myself, but people with disabilities that impact their ability to drive, as well as truly anyone who doesn't own a car or can't get a license for any reason. And that's important to consider. Additionally, if you do need to come in for care or have COVID and you need to come into, for example, a COVID surge unit, not all of those spaces have considered people with disabilities. And it's unclear if they are prepared with accommodative medical devices and technology to ensure that people with disabilities are getting the same quality of care. To be determined how that's going to bear out. And then lastly, there's an impact of PPE, face masks, personal protective equipment, and the visitor restrictions. Now again, as a public health professional, I am not taking a stance that these restrictions and these policies should not be in place, but we need to consider the unequal impact that they do have on members of our community, people with disabilities. So for people with hearing loss, for example, mask use can inhibit the ability to lip read, and that may be critically important in a healthcare setting where people need to communicate critical information. Visitor restrictions also can impact differentially people with disabilities who sometimes require someone to accompany them to assist with communication and even just getting to and from. But in addition to those barriers, there's also real data barriers that impact the pandemic response for the disability community. When we think about how and where we're getting data from people about COVID tests and COVID outcomes, a lot of that information is coming from medical records. Information like age, race, ethnicity, gender identity. And certainly there's been calls to release that data so that we can track COVID by certain groups at the state, national, and global level. But for people with disabilities, that data doesn't even exist. Because most medical settings, we're not even collecting information on a patient's disability status. Lisa Iazzoni, who's a professor here at Harvard, I'm pretending like I'm at Harvard, which I'm not, has been calling this out for over a decade. And in 2011, she wrote the Sentinel paper, Eliminating Health and Healthcare Disparities Among the Growing Population of People with Disabilities. And she said, beyond survey data, little information is available to explore disparities among people with disabilities. Medicare and Medicaid claims files used frequently to investigate disparities in service use for racial and ethnic minorities do not contain indicators of current disability. That certainly has been a perpetual concern in looking at healthcare outcomes for people with disabilities. That's only been elevated in this time, in the time of the pandemic. Additionally, national COVID-19 surveys have been propped up to look at the impact of COVID. But there's limited disability or a lack of disability data included in those surveys, which is an opportunity lost. One example is the COVID-19 Household Pulse Survey, which is a collaboration between the Census Bureau and the CDC, and intends and is looking at the mental health implications, the financial employment implications, and the healthcare utilization impact of COVID-19. But it is woefully under collecting disability. So this survey is now in its second phase. In the first phase, it asked one question for which you could drill down and look at disability to some degree. And that question was, what is your main reason for not working for pay or profit? The potential answer that would flag someone as potentially having a disability was, I am or was sick, not coronavirus related, or disabled. So the concern here is that it is caveating that disability is hinged to not working. So this is now a subset of disability related to labor force, not capturing the whole disability community again. Phase 2 of this survey adds additional questions about disability, but again, are labor force related. These questions asking things like, what type of benefits do you apply or attempt to apply for after March 13th? Social Security disability is one potential answer to these types of questions, and there's a few of them in phase 2. And for anyone that doesn't know, Social Security disability is a federal benefit program for people with disabilities who can no longer work. Again, disability identifier tied to work. So for anyone with a disability that is working, you will not be identified as having a disability in this survey, not capturing the whole community. The third way in which we are missing out on data on the disability community is that cohort studies often exclude people with disabilities, and that's critical right now. So cohort studies that have already been established have been adding supplements or additional questionnaires to rapidly collect information about COVID-19. But historically, these cohort studies have excluded people with disabilities, again, missing an opportunity for information about disability and COVID-19. In 2016, this article in the American Journal of Public Health talked just about this. And this is even more impactful today. People with disabilities are largely absent from mainstream health research. Exclusion of people with disabilities may be explicit, attributable to poorly justified exclusion criteria, or implicit, attributable to inaccessible study documents, interventions, or research measures. And right now, that certainly could impact our ability to track and monitor, especially long-term outcomes of COVID-19 in the disability community. So what are the data implications of all this? So the first is that the COVID-19 disability data may be biased. Nursing homes, as I explained, are just a subset of the disability community. And those COVID-19 national surveys are assessing just a subgroup of disability. So we're only getting a biased sample. There's additional impacts on national COVID-19 estimates. The lack of data to track COVID-19 data, or the lack of data to track COVID-19 among people with disability means we're missing out on tracking a large percentage, a quarter of our population. Barriers to testing and healthcare mean that we could systematically be missing individuals when we're looking at that type of data, people with disabilities. And exclusion from cohort studies means that there's potential limits to the generalizability in this time when we're really considering the population as a whole. So the overall impact is that the pandemic response could be missing more than a quarter of the US population, people with disabilities. So what do we do? How do we get to a more equitable response? Well, the first thing is to prioritize accessibility. I talked about inaccessibility of information, of content, inaccessibility of healthcare spaces, of testing sites, and even inaccessibility of participating in research. It's critical. But in addition to that, we have to prioritize collecting disability data. Without the data, we can't track COVID in this population. But to be able to achieve those first two goals, and what we've learned from studying other groups, is we first need to partner with the disability community. That's critical. As researchers, when we enter into research of a group or a community, it's essential to form that partnership so that you can best understand what is going to work within that community to get to the best outcome. What's going to be the most accessible option? What is the kind of data that you need to do to best identify and determine who has a disability and who doesn't in your study? I want to take a minute to highlight an exceptional trainee working with me, Sabrina Epstein, who is doing just this kind of work. So right now, she is running a qualitative study working with participants with disabilities. She's recruiting from some national disability advocacy organizations. The idea here is to understand how COVID-19 is impacting people with different types of disabilities. The long-term goal is to not only understand this impact, to perhaps inform policy in the short term, but to help us in the long term develop questions for surveys that can be used for research studies to examine the long-term implications of COVID-19 in the disability community. By forming this partnership, we understand that we need to start with conversation with the disability community to understand what the needs are. And I want to end my talk to ask you all to think about this statement. Who counts depends on who is counted. So the pandemic response has largely been data-driven. And as we watch the pandemic curves and the COVID-19 dashboards, it's really important for us all to think about who's not represented in that data. The urgency of this moment has really elevated a need to address health inequities and deepened our understanding that community and population health is not an individual pursuit. It's also reinforced that public health is built on an underpinning of social justice. People with disabilities have long been discounted from society and similarly excluded from research, but I know they're not the only group. I ask for every researcher who's listening today to think about the data you have and think about the data that you don't have. Not just for the statistical implications, but also for the societal ones. During this time, as we move towards a more healthy and equitable society, which I think is all of our goal, there's a global recognition about our connectedness. That we need to achieve health by including everyone, that our community needs to include all of us. And my hope is that disability will be part of that equation. Because from social justice to public health, we all deserve to be counted. I want to thank all the outstanding researchers that spend time with me and have spent time with me to do our ongoing COVID work and have dedicated a lot of time to the work that we're doing. Thank you so much.
Dr. Sweaner, thank you so much for such an engaging presentation. So for the next 15 minutes or so, we'd like to take some questions from the audience, and we will try our best to accommodate as many questions as we can. However, if your question does not get covered, please feel free to reach out to Dr. Sweaner directly. Her contact information is being shared in the chat. And please remember to submit your questions to Tiffany Lemon via the chat function. So the first question we have from the audience is, what are the best practices for epidemiologists who want to start collecting information on disability status within their studies?
Yeah, great question. So I think it would depend on the type of study you're doing. Well, I know it would depend. So there certainly are questions that are used to ascertain or to assess disability in national surveys, like in the American Community Survey, the National Health Interview Survey, BRFSS, which I alluded to. That certainly can be used. And they ask about not just do you have a disability, but they ask about different types of disabilities. And those usually are a good start, although they're not perfect, I will say. Again, there's some complexity to disability. And in my opinion, room for improvement in how we're asking these questions that better honor what disability means to people and how people with disabilities identify with disability themselves. So I know that's not a direct answer, but usually the place to start in an epidemiologic study is to look at what's been used in those large national surveys, those questions that have been validated.
Great, thank you. So our next audience question is, are current vaccine trials including people living with disabilities in their cohorts? What are actionable steps researchers can take to include people with disabilities?
That is another really good question. And, you know, I'm not going to pretend I actually know the nuanced detail of all the vaccine trials because I just don't. But I will say historically, for randomized controlled trials, people with disabilities are excluded. And again, I just don't know. There's so many vaccine trials going on right now. I just can't speak on behalf of many or all of them. But my presumption is that many are continuing that trend of excluding people with disabilities. And it's important to think about that impact. I, as an epidemiologist, understand the reason why you have tightly controlled or restrictions on who you're including in your trial, but then the implications of that on the generalizability of those results. And then when you roll that vaccine out, the implications that may have. And that's an important consideration.
Right. Our next question from the audience is, do you find that confidentiality and sensitivity surrounding disability status presents a barrier to collecting robust data?
Yeah, that's a really great question. And I appreciate that question very much. Certainly, you know, and an interesting question. So the idea that disability is something that is not to be discussed, not to be disclosed, I trust me, I live this experience. I've lived through that. I understand that. But I want to just take a second and have everyone think about why that in and of itself is a problem. Why we have a society that we have created that to be the case, right? Where disability is such a negative connotation that people don't even want to say that they have it. And I think at the root, we have a responsibility as public health researchers to change that paradigm. At the same time, acknowledge and honor the fact that there are people who don't want to disclose, and I completely support that personal experience and decision. So how does that then manifest to data collection, right? I think that comes down to the art of how you ask a question. You know, you asking a question of, do you have a disability, yes or no, is not a good question, right? And it's not a good question for a lot of reasons, but it's not a good question because of the question that was just asked to me, because of the stigma with identifying as having a disability. The questions we ask to assess disability are things like, do you have difficulty seeing even while wearing glasses, right? Or do you have difficulty hearing? Do you wear a hearing aid? So I think that I gave a complicated answer, but it comes down to the art of asking the question, and again, understanding and knowing the population you're working with.
So our next question is some changes made for the pandemic, for example, more options for working or attending events remotely, are accommodations that people with disabilities have long asked for. How do we make sure that these changes remain in place after the pandemic?
Yeah, thank you. That's a wonderful question. So that is a really important point. And I will say that should be the charge of all of us, not just people in the disability community, right? And I think that's long been part of the stopgap. Right? Like we're seeing in other groups and in other spaces, the discounting of people with disabilities shouldn't just be about people with disabilities. And so we all now see the benefit of this, I think to some degree. It's not perfect, but I think lots of us are benefiting. And it's interesting, it's an interesting natural experiment because for so long people have, as the question alluded to, have asked for these types of scenarios, accommodations, and people have been told it's not possible. But clearly we know it is. So I think with moving forward, you know, being an ally to people without disabilities or to people with disabilities, and understanding that just because you can't conceive of a life that someone with a disability leads and understand the things they need doesn't mean it's not possible. We're all living that scenario right now. So I think advocating for it as a community is the way to move that forward.
Our next question is, as we shift from a medical model of disability towards a social model of disability, what are some key aspects of the environment that we could capture in epidemiological studies?
Good question. Yeah, so in thinking about, you know, the parts of the environment that can create a disability, you know, it's important to think about no different than we're thinking about social determinants of health, right? It's the societal perceptions, it's the physical space, it's the interactions with others. You know, I'm hesitant to give a hard and fast, set, fixed list of things that we can capture, but I think, you know, much like we've shifted the way we think about health from what just happens in a healthcare setting to what happens in the community, it's a similar idea, right? Disability isn't something that you just think and talk about in a healthcare space. It's something that is part of your life and is part of you in the community. And I think we have to think broadly about that. So it would depend on the question and the situation, but taking a holistic approach about the societal and the physical, and perhaps even the technology factors that surround the individual.
So this next question touches upon some topics you discussed in your talk. So what epidemiological biases, such as selection bias, missing data, poor quality data, would you say most affect the disability-related COVID-19 data we do have?
Yeah, great question. So from my perspective, you know, that's a tough one to answer because I'm purely speculating. We don't have the data, but I think that to me the biggest issue really is the fact that we just don't have the data on people with disabilities, and that's such a large portion of our population. That to me is among the most pressing issues. If a quarter of our population, and for the barriers and the reasons I stated, inaccessibility of information, the barriers to testing, the barriers to healthcare, plus, I mean, there's many more I couldn't even discuss, that the pandemic may be differentially impacting the disability community. Therefore, the response may not be reaching the disability community in the same way. And so without that measure, that simple assessment of disability, when people in these surveys and in the COVID statistics, we have no idea if we're missing a group that needs to be a target of the pandemic response. That to me is the most pressing issue because it's such a big portion of our population.
So this next question from the audience says, I was very moved by your story about your own barriers to getting a COVID test and would love to learn what solution you ended up finding for your own case.
My solution is that I did not get a test, unfortunately. And I've been asked since about what I think the right solution is for people with disabilities and getting a COVID test, for example. You know, I participated or I worked with sort of a consortium of individuals in the vision community to do a survey of how COVID has impacted people who are visually impaired and blind. And this was a common theme that came out. You know, the concern of the inaccessibility of testing because people don't drive, right? People with vision loss, there's a high proportion that don't drive. And, you know, I think that the best option, while it may not be the most economically, it may not be the cheapest option, is that you have to meet people where they are, right? We have to find a way to get testing to people. I think this is going to probably become more and more urgent as flu season starts and we're thinking about getting vaccinations to individuals as well. And there could be lots of reasons that because of changes in transportation, concerns with infection, in going into the community in the ways that we would have before, the adoption rate of vaccination may be lower in people with disabilities, perhaps in certain groups. And so I do think there needs to be an effort, again, because this could be a significant proportion of the population, to meet people where they are and find ways to either go to their homes or other innovative strategies to get testing and the flu vaccine to people so they don't have to come in.
So this next question is related. So do you have suggestions on how we can get our healthcare institutions to more specifically address accessibility for disabled patients related to COVID-19?
Great question. I think, yeah, so in my experience, the best way to move a healthcare system is with data. So again, I think one of the first steps is to collect data on patients about disability and see if there's differences in outcome, differences in how their experiences. And Beyond that, it's, the advocacy certainly is helpful, but I think that probably most healthcare systems, to make, sort of more seismic changes, do need data to understand the proportion of their population that has a disability. We don't even have a good handle on that in many healthcare settings, how many people are coming in with different types of disabilities. And therefore, it's hard to know what the need is and how to best meet that need.
Similarly, can you speak a bit to how different disability communities have different obstacles to care and how that relates when gathering data?
Yeah, absolutely. So that speaks to one of the points I made early in my talk, which is that, under this umbrella of disability, well, different types of disability, those differences really matter, right? And there are important differences. So you think about someone with a vision impairment like me, that there's challenges to getting to a healthcare appointment, navigating within the healthcare facility. If someone hands me a after visit summary or paperwork, it's a struggle, right? Versus someone that has a hearing loss or is deaf, that's a different aspect. The barriers there are communication with the provider in the appointment, perhaps. Making the appointment may have been a barrier. Depending if they're using telehealth, for example, may have been a barrier. Individuals with mobility disabilities, again, it's getting to and from the appointment. Is there access to the medical table? In some instances, that's not even accessible. Getting in the door to the medical facility is not always accessible. Is there a way to weigh and measure an individual that is a wheelchair user, for example, and to collect the data that might be needed to make diagnoses? So there's multiple barriers, and you're correct, whoever asked this question, in that those barriers do differ. And I apologize, can you repeat the second half of that question? Is how to address it? Is that?
Yeah, I guess how to think about this when gathering data specifically.
How to think about this and gathering data. Yeah. So again, this gets back to my point of, the questions to assess this in data are not just, do you have a disability, yes or no? The questions that we ask or should ask are more specific. They're asking specifically about disability types: vision, hearing, mobility, cognitive. Just for example, that's a short list. There's a broader list to use. And from that list, then you can examine, outcomes, health outcomes in a cohort study or wherever you're looking in a healthcare setting by disability type, as well as then you can group them together to look at by any disability. So you can honor those differences, but also look under the umbrella of any disability.
The next question we have from our audience is, how do we at academic medical centers support faculty members with disability in their career development?
That's a great question, and something I certainly do spend a lot of time on as well. I think not unlike the research, it's about making sure people are included and that there is an effort to understand that, having a career with a disability is different, right? So honoring that difference. I think that there's a need to start to acknowledge that disability sort of under the umbrella of diversity initiatives. It's a critical component to some of the work that's being done in diversity initiatives, and understand it should be part of recruitment, retention strategies, and that we need to make sure that there's mentors for people with disabilities, for students and learners. That's a critical component. And just like we're doing for other underrepresented groups in academic careers, we need to think of disability just the same.
So the next question we have is, what is the consideration of causality versus correlation for the outcomes discussed here?
Say that, I'm sorry, repeat that again.
Yeah, so the question is, I guess, how do you consider causality versus correlation for the outcomes discussed here? And
so I guess I'm not sure on which specific topic, I have to be honest with you. So I'm trying to think through the data that I showed. Causality for correlation on, yeah, I guess I'm just not sure what that question would be related to.
right.
Disability or to sort of the nursing home data. I don't know if they gave any other.
Yeah, so specifically for nursing home data.
Oh, okay. Yeah, so causality is, you know, I'm not, that is first and foremost, you know, not my work. I'm presenting the work of others, but so I don't want to overspeak here, but it is correlation, right? It is certainly, and I think that, you know, causality, there would need to be a lot more work going on to fully examine that.
Great. And then I think that's all we have time for in terms of audience questions. But I did also want to read a comment from Dr. Lipsitch, who is the director for the Center for Communicable Disease Dynamics. And he says, "Thank you for a very important and timely talk. This reminds me of a WHO publication on the ethics of surveillance that should be better known." And we will share the link in the chat. And this publication makes the strong argument for a right to be under public health surveillance on exactly the grounds that you describe here, that you can't provide resources for a problem that isn't known or quantified.
Thank you. I appreciate that comment.
So on behalf of the Center for Communicable Disease Dynamics and the Harvard T.H. Chan School of Public Health, I'd like to thank Dr. Sweaner for joining us today. Thank you so much. It's been a great talk. And I'd also like to thank everyone online for tuning in to the first talk of the COVID-19 and Health Inequities seminar series. And we hope to see you at our next presentation on Thursday, October 1st, featuring Dr. Jarvis Chen for his talk on tracking the unequal burden of COVID-19 in the United States. Thank you so much, everyone, for joining, and thank you again, Dr. Sweaner.
Thank you so much for having me. I really appreciate it.